Welcome to Physician Focus. I'm Dr. Bruce Carlin. When it comes to individual health, men fare far worse than women. According to the U.S. Centers for Disease Control, men die at higher rates than women from the top 10 causes of death. Men are twice as likely to die of heart disease, more prone to be killed or injured in accidents, and more likely to suffer from drug or alcohol addictions. Additionally, a third of men over 20 years of age have high blood pressure, and nearly 36% are obese. What causes men to do so poorly with their health as compared to women? What are the main health risks that men face? And what should men do to reduce those risks? With me to examine those and other questions about men's health is Dr. Frederick Schwartz. Dr. Schwartz is a physician on medical staffs at UMass Memorial Healthcare and St. Vincent Hospital, and an assistant professor at UMass Medical School in Worcester. Board certified in internal medicine, he is also co-chair of the Men's Health Committee of the Mass Medical Society. Welcome, Dr. Schwartz.
Thank you, Bruce. It's nice to be here.
So why men's health? Why are we focusing on that? Where have we gone wrong?
Well, men have, for many, many years, have really not taken good care of themselves. There seems to be this macho attitude, this pseudo-masculinity, where men feel that to access health care is not part of their creed. And so they delay. They really are in denial.
They don't ask for directions.
They don't ask for help until it's too late or until it's way down the road. And so what we'd like to see happen is that men are more proactive and establish that relationship with their physician in the early part instead of waiting down the line.
So in the 60s, there was Our Bodies, Ourselves. The women started taking charge of their health and taking charge of their bodies. Is this sort of are we at a point where we're making a reaction to it and finally catching on to that really great part of the women's movement?
Absolutely. I think men have finally wised up, and I think the physician community, the medical community, understands that they need to do their part too in facilitating men getting in to see their doctors on a timely basis so they can get the care that they deserve.
So any particular items in terms of changing men's psyche that we can do? I mean, the two of us do it in our private practices.
Yes.
But
well, there's really, I don't have any mental tricks to play. I do think that if we look at common subjects such as head trauma, head injury, we're all familiar now in the news media, you can't help but hear about CTE, chronic traumatic encephalopathy in athletes.
And that's the concussion syndrome.
Exactly, the concussion syndrome. And men who played football, who played contact sports for many years ignored themselves. And now what's happening is their families are left with disasters. And hopefully the male and the female population have woken up now and understand that head injury is a real problem and you have to take care of yourself.
So you're saying that this is part of the men's denial, that I'm tough, I can handle this, let me just shake off that fuzziness in my brain.
It was almost like a shameful act to seek attention, to draw attention to a physical or emotional ailment would be frowned upon.
Would not be manly?
Would not be manly. And we're looking to say to guys, you're human just like anybody else. Take advantage of what we have to offer you.
So what are the leading causes of troubles with men? What are the leading causes of death?
Well, I think you mentioned in your opening piece that drug addiction, substance abuse, alcohol abuse, nicotine abuse, these are things that men and women do to themselves that are very unfortunate. So that's certainly heart disease, high blood pressure, diabetes, cancer. I think one area where men can do a better job is being proactive when it comes to cancer screening. And we can talk about that.
Why don't we start right now and talk about it? Good Good segue there, Fred. What things should men do that are peculiar to men?
Okay. So
in terms of cancer screening.
So I mean, that's an important point. There's only the one organ really that men have that women don't have. For instance, men have a colon, women have a colon. Both need to have that screened in an appropriate manner. Skin cancer, huge epidemic in this country. Men and women both have to be aware of that.
Are you saying that men get less colonoscopies than women, or do we know that?
I have no idea.
Okay.
I do know that in my experience, it's harder to get a man to do something. When I have a man in my office and I say, Joe, it's time to get your colonoscopy, their hackles are raised and they just don't seem to be inclined to follow through on that. Women seem much more inclined, in my experience, in following through on the recommendations that we're promoting to maintain their health.
So you're saying that the major issue with cancer screening are the ones common to men and women, but it's the men's reluctance or diffidence about getting a screening or getting their care that blocks some of this from getting done right.
Yeah, I mean, it's...
So what about the specific peculiar to male problems?
Well, we have...
What about prostate?
Right, so we have prostate cancer, and the problem with prostate cancer screening is that to this date, we really don't have a good screen. When I say good, I mean a screen that would be effective in identifying something that we can rectify without doing harm to the male patient. There is one blood test that is in common use, the PSA, the prostate-specific antigen test. That test has been used for probably 20 years. What we know now from our recent research is that test is unfortunately not effective in identifying the bad actors. By bad actors, what I mean is those prostate cancers which are going to do the most harm, that are going to spread and invade that man's body. Unfortunately, we get too many men identified with this test who have relatively benign courses where it's going to remain, the cancer will remain in the gland itself. It will not spread. It will not cause harm to that male patient.
So that's the cancer that you'll die with, not from.
Yes, I think it's well recognized that at autopsy, men over 65, a majority of them are found to have prostate cancer in the gland itself, but they die of something else. So we're not looking to kill the cancer, we're looking to help the man. And unfortunately, many men who have been identified as having prostate cancer go on to get treatment for prostate cancer. Unfortunately, many of these men end up having side effects, complications from those treatments that make them worse than when they began.
So, but the main issue is that it's not necessarily bad to get screened. It just needs to have a very good discussion with your physician as to the meaning of results of each of those tests. I notice that the guidelines now say that watchful waiting is a very good option as opposed to what we used to do, sort of throw our hands up and say, oh my God, that test has crossed some magic threshold, we should absolutely do something. We don't necessarily anymore, and that's within the guidelines. But you're still saying that we should get reviewed. How do you counsel your patients in terms of prostate cancer screening?
Well, I think the key thing is an individual approach. Every man is different. I think we're aware that African American males have a higher incidence of prostate cancer, and they are subject to develop that cancer at a younger age, so that we may want to be more aggressive, if you will, in doing testing on an African American male. We look at family history, we look at personal history. What we want to do is basically do a risk assessment for that individual patient. And that is really part of the doctor-patient relationship, which is only established when you see that physician and you see your patient over a number of years.
And regularly.
And so, right, and so you can establish that trust because you're dealing with important things here and you're making important decisions. And to be able to do that and feel comfortable in making those decisions, you need to have that trust.
So, but you're still saying that you do some prostate cancer screening. Obviously, a digital rectal exam every so often is not either party's favorite part of the day, but an important thing to do. And so that you also fold in PSAs according to your physician and a discussion and a careful discussion with your physician about your true risks and how to manage the results of the tests when you get them. So let's talk about other items. The prostate isn't only capable of cancer, it's capable of gumming up the works. How do you get guys to pay attention to that?
Well, first of all, a lot of men are embarrassed to talk about things like urination, and we need to get them past that point. But men develop things like a weak stream when they urinate. They develop things like dribbling. They develop things like incomplete emptying of their bladder. They wake up at night more than once, more than twice, sometimes 3 or 4 times to empty their bladder. They find that when they're out with their families or spouses doing whatever, that they have to excuse themselves in the middle of a movie, in the middle of an event to use the restroom. So these are all signs of having an enlarged prostate. And this is something that the physician can help them with.
And so how do you address this on a regular basis? Do you, with your patients, how do you get them to talk about it? Is it a difficult thing? And I don't find it difficult in my office. If you've established that relationship, you can say, you're dribbling.
Yeah, I have no trouble. No, I think once you have that relationship, I have no trouble at all establishing, asking those questions. You need to ask the question, and then you need to let that man know that you can help them with that. You can help them reduce some of those symptoms, whether that means lifestyle modification, whether that means medication, whether that means referral to a specialist, as a urologist, and if so, discuss what kind of surgical procedures might be available to them. The important thing is to have that conversation.
But if I'm hearing you right, you're getting the patient into the office is the starting point of all this, and on understanding that this is sin to which all flesh is heir to, that at some time or other all guys are going to have a slowing of their stream, they're going to have a little dribbling, they're going to have all the problems with urination that enlarging prostates give us because they grow with age and we're living longer. But getting over that hurdle of saying, look, I've got this problem, and hey, guess what? There's something you can do about it.
Absolutely. Men need to know that they can get reliable and helpful advice from their physician. And these symptoms can be lessened, they can be controlled. But again, every person is unique. It's not like a mandatory thing. It's not like you have a fatal disease that's you have to address. And every person has their own threshold for when they think it warrants further attention. But this is something that you discuss with your physician and decide together in a mutual method of how and when to go about things.
So let's talk about other issues. What about high blood pressure in guys? Are we less prone to getting it treated than women?
I'm not aware of that. I haven't found that in my experience. Most of my male patients are just as willing to be treated. I think the thing you have to be careful with men is the side effects from some of these medications, especially when it goes towards things like impotence or inability to sustain an erection adequate for intercourse. So that is a concern, and you need to be sensitive to your patients, to your male patients' experience with that medication, and you need to be able to give them the proper information up front so they can make an informed decision.
The problem that I often have with this is that the high blood pressure itself is probably the thing that's causing the erectile dysfunction. And when you treat it, and the guy says, "Well, I've got erectile dysfunction," I say, "Yeah, we can help you with that, but you still need to treat the high blood pressure, because that's really what's at the root of everything." So let's talk about erectile dysfunction, because that's another uniquely male problem. I don't see a problem with guys coming in because they, when things aren't working, to come tell you about that.
I agree with that, Bruce. I mean, I think if there's one thing where men are willing to come in and talk to their doctor about it, it's when they can't get an erection, and it's interfering with their relationship. It's interfering with their intimate acts, and that's where I found men from the very get-go have been willing to come in, if for nothing else, to get that pill.
So it's sort of the hook that brings them in to get
exactly.
the care for everything
and
else.
In some respects, it's maybe not a bad thing, because you can take full advantage of their being there, and you can raise other topics while they're there.
Right, and cover the other issues. Let's get your other cancer screenings. Let's get your other things. So a lot of guys come in and say, "All right, I've got erectile dysfunction. That's because I've got low T." How do you handle that response?
That is a very complex and difficult subject. My personal perspective is that for most men, it is not the factor behind their impotence, and I'm not eager to initiate replacement therapy. Now, that doesn't mean I never do it. There are certainly men who have impotence where I do get testosterone levels and work them up for impotence with biochemical testing.
I know there's a big kerfuffle in the endocrine literature about, is there an absolute level of testosterone that's right? And as I understand the discussion, it's between, is this just natural aging that we're talking about, or is this a real disease? And you certainly know that high levels of testosterone are associated with extra heart disease. So I think I'm much more in your camp about, I don't think it's as much of a problem, and it's certainly not the cause of erectile dysfunction. It can be the cause of low libido.
Right. And I think there was a recent study in the New England Journal of Medicine. It appeared in the February 2016 issue, and it came out of the hospital at the University of Pennsylvania. And in that study, Peter Snyder, an endocrinologist, a hormone specialist, an endocrine specialist, he looked at men 65 and older, and he divided them into two groups. In one group, he gave them a placebo. In the other group, he gave them testosterone. And it was impossible for the patient, for the subject, to know which one they received. So it was a blinded study. And they looked at certain parameters to see if that testosterone would improve their sexual function, their physical activity, and their overall vitality. And they found that with sexual function, in terms of libido, it did improve. So that
So
the men
libido
that,
being the
the
desire
sex drive,
to have
yes.
sex.
So the men that got the testosterone supplementation did have an increased sex drive. And their sexual activity, the frequency, did increase a statistically significant amount. Not a huge amount, but statistically significant. It did meet those criteria. However, when they looked at physical functioning of that man, in terms of something called the 6-minute walk test, those men were not able to do any better than the men who got the placebo. And when they looked at vitality, which had to do with fatigue, again, those men and had no improvement. So it was limited to their sexual function. And the question is that a rationale to provide that medication for these men? And it's something I think that's still being worked out.
And also, at what level do you do it? And I think that's the biggest issue.
And at what level do you decide? I mean, who decided? And this is something that I'm not aware of. Who decided that this is the cutoff level, that if you're above this, you're okay, or below this, you're hypogonadal? I mean, these are things.
Hypogonadal meaning small sex organs.
And having a low testosterone level.
Right.
Who decides where to draw that line?
And also, if I'm hearing you correctly, it also has to do, it's an age-related phenomenon too.
Absolutely.
Our testosterone is going to fall off as
Absolutely.
we get older.
Right, and I think that's part of the aging process, which is something healthy.
Well, we still have a few minutes, so I thought I'd give you a chance to tell about what the Men's Health, what our Men's Health resources and what the MMS is doing about men's health.
Yes. Well, thank you for asking. I am very proud to be the co-chair of the Men's Health Committee for the Massachusetts Medical Society. And we have been putting on, as one of our major activities, a Men's Health Symposium. And we do it every year. We do it the week of Father's Day. And we do it to provide education to the medical community on topics of men's health. And every year we have outstanding speakers from not just Massachusetts, but from across the country that come to educate us on how we can improve men's health.
And what's our turnout been?
Well, that's something, it's a work in progress. And we are, we have a good turnout, and we're looking to always to improve on that. I think as we get the word out, and we will grow our audience.
So, if you had to say what the important items are in terms of men's health, what are we missing? What are the things you'd say to our male audience out there and our female audience who want their friends from the distaff side to improve their health? What are the important items?
Mm-hmm. Well, number one, by far, is to get in there and see your physician. I am a firm believer in primary care. I am a firm believer in establishing that relationship with your physician. And that relationship cannot be established with one visit or two visits. It takes time. It takes having that annual exam year after year to build that relationship, to build that trust, and to allow you to feel comfortable sharing these are sensitive, these are very intimate issues, and you need to take the first step and get in that office, and that will go a long way.
Well, this has been, there's one other topic that we missed on. You were talking about obesity in men. Do you have some final words on what we should be doing about that, and peculiar to men? Obesity is really a major issue in this country. Recent information actually suggests that more women are obese percentage-wise than men. But 35% approximately of men in this country are obese. They meet the body mass index criteria for obesity. And the body mass index is just sort of
it's a measurement based on height and weight.
Yeah.
And there are tables that you can easily access on the internet to help, and your physician automatically, with their electronic medical record, can automatically give you your BMI. Yes. Yeah.
And what are the things that you're saying to men? We should be paying some attention to this as well.
Yeah, and I think one of the keys is exercise. And one of the things that I think is healthy lifestyle, and exercise needs to be part of that equation. So that it's very, very important to in a sense, give your patient, your male patient, an exercise prescription to instruct them that it's important that they get out there and do something, what they like to do, so that they'll do it. And they do that on a regular and consistent basis.
Let's turn to a different subject. Let's talk about men being slightly more prone to substance abuse with alcohol or drugs. What do you think brings that on?
That's a great question, Bruce. I think men feel a lot of pressure to be financially breadwinners for their families. And when they go through episodes like we had in 2008, where we had a huge recession, where people lost their jobs, they were scrambling and they sought refuge. And unfortunately, instead of accessing their physicians and the healthcare system, sometimes they did it on their own. And that meant alcohol, and that meant drugs.
And we've got a lot to offer them.
We do.
That's again getting
and
into the.
Absolutely. And so if the patient, if the man will come in and see us, if it's alcohol, we can refer them for counseling. We can refer them to Alcoholics Anonymous. If it's for opiates, we now have resources for that. So the point is these pressures are always there. We need to get that patient in the office.
Well, thank you. For more information on men's health, visit our homepage at physicianfocus.org. I'm Dr. Bruce Carlin. Thank you for watching.
I'm Dr. Dennis Dimitri.
I'm Dr. Monica Burrell.
Prescription drugs are valuable medicines, and when taken under a doctor's supervision, provide effective pain relief for many conditions.
But the abuse of these powerful drugs has become a serious public health problem in Massachusetts and across the country, resulting in the needless deaths of thousands of people.
If you are prescribed opioids or pain medication, talk with your doctor about the risks and benefits of the medicines and explore different ways to treat your pain.
The safe use of prescription drugs comes when physicians and patients work together to promote healing and good health.
Medicines cure, heal, and relieve pain. Use them carefully, store them securely, and dispose of them properly when no longer needed.
What you do can make a difference. For more information, visit the websites of the Massachusetts Department of Public Health or the Massachusetts Medical Society.
I'm Dr. Frank McMillan.
And I'm Dr. Raj Devarajan.
Colorectal cancer is the second leading cause of cancer-related death in the United States, claiming more than 50,000 lives each year.
The cancer occurs in the colon and rectum, parts of the large intestine, and is caused by growths called polyps that can turn into cancer.
Screening for colorectal cancer saves lives, but 23 million American adults, about 1 in 3, don't get screened as recommended.
Colorectal cancer affects men and women, and the risk rises with age and a family history of the disease. If you're over 50 or have a family history of the disease, early screening is recommended.
Screening can reduce the risk of colorectal cancer by up to 90% by finding and removing the growths before they turn into cancer.
For more information on colorectal cancer and the different screening tests available, visit the American College of Gastroenterology.